Pancreatitis is defined by ATI as an autodigestion of the pancreas by pancreatic digestive enzymes that activate prematurely before reaching the intestines. Acute pancreatitis can range from mild to necrotizing hemorrhagic pancreatitis, which causes widespread bleeding and necrosis. Acute pancreatitis is caused by a blockage of the pancreatic duct by gallstones, infection, tumors, or trauma. It generally occurs within 24 to 48 hours of a heavy meal or an episode of binge drinking. The complications and effects of acute pancreatitis can be reversed if treated promptly and lifestyles are changed. Acute pancreatitis is an inflammatory process of the pancreas where the pancreatic duct becomes blocked in the same area as the common bile duct, often by gallstones, as they share this area that leads to the lower intestine. The pancreas is then unable to release enzymes due to the blockage, and this causes normally inactive pancreatic enzymes to become activated. Once activated, amylase, lipase, and protease begin to auto-digest the pancreas. The pancreas also has a malfunction in the islets of Langerhans and begins to become unable to regulate blood glucose levels. During this occurrence, the tissues and cells outside of the pancreas, known as the epithelial cells, begin to have dysfunction and are unable to release bicarbonate as they normally would, which throws more body systems off. During all of this happening, the pancreas becomes inflamed and irritated and begins to cause the patient pain. Common clinical manifestations include sudden intense pain in the left upper quadrant and epigastric area that can often radiate to the back. The pain will feel worse when the patient is lying supine, and respiratory distress and hypoxia can be common. Pain occurs typically within 24 to 48 hours of a heavy meal or a binge drinking episode. Pain may be relieved by leaning forward, sitting upright, or lying in the fetal position. The patient may have complaint of nausea and vomiting as well as weight loss if this episode has been going on for a period of time. Colon and Turner signs are indications that the patient is experiencing internal bleeding. The patient may appear jaundiced and have absent or decreased bowel sounds. They may also have ascites or tetany. The patient may experience hyperglycemia and can present with more moist skin and fruity breath. Hypovolemic shock and multi-organ dysfunction failure can occur, as well as DIC. Acute pancreatitis can be life-threatening if not treated promptly. Common diagnostic testing that can be performed to indicate if a patient has acute pancreatitis or not can be blood work that determines increased levels of amylase and lipase, as these levels can be 5 times their normal. A CBC to determine increased white blood cell levels, which can indicate an infection. Decreased hemoglobin, hematocrit, and platelet levels, which can indicate internal bleeding. Elevated liver enzymes and bilirubin levels are also associated with biliary dysfunction. Serum calcium and magnesium can be decreased. Serum glucose levels can be elevated due to the decrease in insulin production by the pancreas. Erythrocyte sedimentation rate will also be elevated. Electrolyte levels can be used to examine and test for any fluid imbalances. CT with contrast and ultrasound may be used to view the pancreas and biliary tracts for any obvious abnormalities and dysfunctions before any more invasive procedures are performed. ERCP can be used to view the pancreas and biliary ducts, as well as to open these with stents and removal of gallstones. In some cases, GI surgery is required to treat the cause of the blockage or complications from the pancreatitis. Complications of acute pancreatitis can include severe pain, type 1 diabetes from destruction of beta cells, which can give you hyperglycemia, fluid and electrolyte disturbances, ascites, malabsorption, internal bleeding, which can be indicated with colon or Turner signs, cysts, abscesses, ruptures, and infections, which can lead to sepsis, shock, multi-organ dysfailure, and DIC. Medical management of acute pancreatitis is aimed at pain control and pancreatic rest through the use of MPO status. IV fluids are used for hydration. Maintenance of an NG tube is used to remove secretions from the stomach and to decrease gastric distension. Administration of opioids for pain management are generally used, although morphine is avoided because it can cause spasms at the sphincter of Oddi. Administration of antacids and PPIs are used to control acidic secretions. Antiemetics are used to control nausea and vomiting. Anticholinergics are used to decrease vagal stimulation, to decrease GI motility, and to inhibit pancreatic enzyme secretions. Antibiotic use is used for infections, obviously. TPN can be used for severe acute pancreatitis when the patient has had foods withheld for a period of time and is becoming malnourished. Administration of insulin may be used if the patient is severely hyperglycemic. Pancreatic enzymes can also be prescribed for this patient since theirs aren't acting the way that they should. Pharmacological interventions include educating the client about proper diet, which would be low fat, moderate protein, and no alcohol, educating the client about eating small bland meals, and also educating them about what could have caused this episode to occur and ways they can stop it from occurring in the future. Nursing judgments for this patient will be made using evidence-based practice, national standards of care, and input from the patient and their caregivers so that they may receive the most appropriate care possible. Professional identity for this patient will be that care will be given in a professional manner to national standards. This patient will be cared for and advocated for, as well as given care that is within the scope of the registered nurse. Spirit of inquiry is promoted for this patient through education of what could have caused this episode of acute pancreatitis and ways to prevent it from occurring again, such as through diet and lifestyle changes. Human flourishing is promoted for this patient through pain management, pancreatic rest, and appropriate medication administration. Human flourishing can also be promoted through patient education of maintaining a diet free of alcohol and consuming a low-fat, high-protein diet.